Dear learners, welcome to the session of this MOOC which is titled Economics of Gender and Development. This is week 9 whereby we will be discussing various aspects of gender inequality and other social dimensions. The name of this 29th module is Some Broader Aspects of Gender Inequality. I am Dr. Mridushmita Duara, Assistant Professor of Social Work, Krishnakanta Khandiko State Open University, Assam. I welcome you all to this particular video session where we will be focusing on two main aspects: gender bias and gender inequality in terms of opportunities available in the sector of health and education. Let us explore the Global Gender Gap Report of 2025, which was done by the World Economic Forum. In this report, it states that India ranks 131 out of the 148 countries. So therefore, it is not a very good scenario. It has slipped slightly from the 129th position that was last year in 2024. India's overall gender parity score is roughly about 64%. Health and survival of about 96% parity can be seen overall. And for educational attainment, it is about 97.1% of parity. Therefore, it indicates that India has closed roughly around 96% of the health gender gap and about 97% of the education gender gap, meaning relatively smaller disparities compared with other sectors. Now, if we see here the parity achieved so far, in case of education 97.1%, which means that the remaining gender gap is around 2.9%. Similarly, in the case of health, the parity achieved is 95.4%, which means that 4.6 gap is still remaining. Now, why does this gender gap exist? If we explore the gender gap in the sector of health in India, we can see that India's performance in the health and survival dimension remains relatively weak compared to many other countries. The country's health parity score is low, placing it near to the bottom globally in this sub-index. The health index mainly reflects the sex ratio at birth, that is the number of male and female born, the healthy life expectancy of women versus that of men. Although India recorded some improvement in parity, this was largely due to slight gains in the sex ratio at birth and life expectancy measures. However, the report, that is this Global Gender Gap Report by World Economic Forum of 2025, states that improvements in life expectancy parity do not necessarily mean better health outcomes overall, because both male and female life expectancy is declined slightly. The overall interpretation here in terms of health is that there has been small improvement in gender parity and slightly still ranked very low globally in terms of health. There is persistent demographic imbalance and health inequality that we see in the Indian scenario. Now, gender bias and gender inequality in terms of opportunities available in the health aspect, that is in terms of accessibility, in terms of healthcare aspect, we can see some form of gap and biasness and inequality that exist. Now, what do we mean by the two terms sex and gender? It is important to understand the meaning of these two terms because though both the terms are used interchangeably, the term sex refers to the biological understanding, whether a person is born as a male, a female, or a transgender. That is only the biological aspect. And the term gender, as we all know, has a social construct. It mainly focuses not only to the sex that you are born with, that is male, female, or transgender, the third gender, or the term gender here mainly denotes the masculinity and femininity characteristics that are associated with each gender. Therefore, how one is expected to behave based on the gender identity is something that the society determines. This particular gendered aspect actually affects the health and overall accessibility and decision making and various characteristics all throughout our life. Gender inequality or inequity is how we see that affects life of every individual. Gender equity that leads to health infrastructure inaccessibility, and it refers to the systematic unfairness to public health provisions. So therefore, gender inequity affects the overall health of an individual. Here we see that accessibility to healthcare, to education, and all other different aspects is greatly determined by our gender that is socially defined. And the education of the mother, that is the one who is looking after you or looking after a child, the mother's education and accessibility to healthcare also greatly affects the health of an individual. Secondly, the decision to take test, it may be HIV test, it may be test regarding any other life-threatening disease or any other illnesses. Who takes the decision about whether you can go for a test or not? It is usually seen that, especially in Southeast Asian countries, the women seek the permission of the other family members or the husband and elders or any other male member of the family, and does not decide herself whether she should go for a particular health checkup or whether for certain tests that needs to be done. This healthcare seeking behavior determines whether you have accessibility to health or not. The health seeking behavior, especially in case of mental health, we see that there is a lot of discrepancy. Women who mostly neglect their own health and especially the mental health condition is greatly seen in our society. Access to health awareness also determines how well you are having accessibility to healthcare or not. First, one needs to be aware that whether I should go for a doctor or I can deal with it at home, or whether it is important to visit a doctor, it is decided by the family members mostly rather than the women herself. So that is a great hindrance to accessibility to healthcare. First of all, we need to create awareness about the different health conditions, the different diseases, and why sometimes seeking medical help is extremely important. Now, since we see that most of these decisions are gendered or socially determined by the other members of the society, therefore, we also see closely connected to this particular aspect of gendered behavior is toxic masculinity. Toxic masculinity, the word masculinity means you have to show, a male member has to show how manly he is. Sometimes taking alcohol or any substantive abuse or cigarette smoking is considered to be manly. So such toxic masculine behavior adversely affects the health of a person, of a male. Similarly, for the female, again, female genital mutilation is a great harmful phenomena that takes place in the society. So therefore, some harmful socially behavior expectations are there in the society that is harming the overall health of these specific women or men and also the other gender. So we see that there is gender gap apart from the wage gap, which is purely an economic aspect. Health and wellness is affected also. That is also one main indicator of gender gap in our society. We have to understand that physiology of women is overlooked and has been overlooked since so many decades. Cardiac and mental health accessibility gap is still there. In case of cardiac health, in case of mental health, there is less accessibility for the women. And also there is gap in healthcare research. There has been hardly any research until around 1993 where healthcare research was only limited to reproductive health of a woman, while excluding all other aspects of a woman's body, of a woman's anatomy. So, lack of diversity of healthcare in terms of the female body is another big hindrance to accessibility to healthcare, and also lack of scientific research in this sphere. Therefore, we can say that the scientific community was much behind in this sphere of overall aspect of overall healthcare, both mental and physical, of a female body and other genders. The second here issue is differential treatment. Differential treatment or less quality of life that is usually seen where the women get chronic conditions. From around age of 20 to 49, we see that there is higher rise of patients of female who are becoming diabetic. They have higher risk for these life-threatening diseases, and also muscular pain is higher among women. But this aspect is completely ignored. People, even researchers, have failed to understand that muscular pain among women is much higher, while pain in women is usually considered to be an emotional reaction or emotional aspect of when a woman expresses her pain. It can be both physical pain as well as emotional pain. Cardiovascular research is less done among women. That is another hindrance here. So these aspects remain unexplored scientifically, and still further research and understanding is required. Social determinants of accessing healthcare is greatly determined by your socioeconomic status. The mortality and morbidity rates also differ in terms of the social class, caste, race, ethnicity, and depends on the accessibility to this healthcare. Whether you are in a rural area or an urban area, whether there is proper health infrastructure or not, all these factors determine the accessibility and taking healthcare provisions. So, lack of accessibility, and also we have seen that a woman usually ignores her own health due to mainly focusing all the other members of the family. So maternity care that is actually needed, the extent of maternity care that is required for a female is sometimes lacking. So maternity care, reproductive health, and overall health of the women needs to be looked at from a holistic perspective. We see that race and ethnicity, and there is a huge link where studies have shown that women's cancer is closely linked to the race and ethnicity that she belongs to. The elimination of systematic discrimination is important here. The geographical locations around the globe determines what kind of medical facilities infrastructure is available. Similarly, the occurrence of diseases and the way you are dealing with a particular life-threatening disease is determined based on your geographical location, accessibility to health infrastructure, and healthcare research that has been done to get over or eliminate certain diseases. We cannot ignore the fact that domestic violence, substance abuse also affect the health of a woman. It is seen that the risk factors differ for every kind of illness in the body of a female. Sample for gender-based research should be inclusive in nature. Otherwise, it will be only a partial perspective that is being presented, and no breakthrough research in healthcare can be done if the samples are not inclusive in nature. Coming to women's reproductive health, it cannot be understood only through biological processes such as pregnancy, menstruation, or menopause. It must also be examined in relation to gender relations and social conditions. As mentioned before, sex refers to the biological traits linked to reproduction, while gender refers to socially constructed roles, expectations, and power relations that shape women's health and experiences. Reproductive health outcomes therefore emerge from the interaction between biology and social environment. So, biologically, women experience reproductive events including pregnancy, childbirth, hormonal changes, and menopause, which influence their health risk and medical needs. However, gender inequalities strongly affect exposure to reproductive risk, access to family planning services, and the ability to make decisions about sexual and reproductive behavior. So, who decides how many children you are going to have, whether a woman wants to be pregnant or not? Who takes the decision? That is a question. Does the woman always have the right or the liberty to choose or decide for her own body? So, this is something which we all need to think about. Example is difference in policies, economic deprivation, and unequal power in sexual relationships usually take the decision on behalf of the women. This can increase unintended pregnancy, early infection with sexually transmitted diseases, or poor maternal outcomes. Reproductive health is shaped simultaneously by social structures and biological characteristics. Understanding women's reproductive health therefore requires attention not only to medical care but also to gender equality, social justice, and access to resources. Only by addressing both biological and social determinants can effective public health strategies be developed. Now, another social problem that exists in our society that is a big hindrance to the women's health is female genital mutilation. It refers to the partial or total removal or injury of female external genital organs for non-medical reasons. It causes serious physical, psychological, and social harms. Immediately after the procedure, girls suffer intense pain, excessive bleeding, swelling, fever, and infections due to unsterile instruments and lack of medical care. It can lead to shock or even death of a female. Long term health consequences experience chronic pelvic infections, urinary problems, menstrual difficulties, infertility, and formation of scar tissue or cysts. So, sexual health is deeply affected due to female genital mutilation, and there might be lifelong pain during intercourse and reduced sexual sensation. During pregnancy and childbirth, women face higher risk of obstructed labor, severe tearing, postpartum hemorrhage, and complications for the newborn. The psychological impact is very intense in nature. For example, it might cause anxiety, depression, and post traumatic stress, low self esteem, and fear of medical examination or relationships. Socially, the practice of female genital mutilation it usually leads to controlling women's bodies and sexuality. Often it violates human rights and endangers the physical, emotional, and reproductive health of girls and women throughout their lives. Coming to India's National Health Policy of 2017 and Vision 2035 aim to build an inclusive leadership structure covering political, administrative, technical, and managerial roles at national and state levels. However, in practice, doctors are usually prompted to administrative positions based mainly on seniority rather than formal leadership or management training. In the same time, women remain significantly unrepresented in the leadership roles within the healthcare system. Data from 2022 showed that women had only 18% of leadership posts. Workforce statistics from 2020 also indicated that women accounted for just over 14% of India's medical doctors. Although some states such as Kerala have examples of women heading major medical institutions, many trained female doctors are not active in the workforce. Research suggests that nearly one-third of medically educated women are not employed, and among women aged around 30 to 40 years, that is about one-fifth out of entire professional practice, they are often engaged in household responsibilities. Even at the highest institutional level, female representation has been minimal. For example, only one woman has served among many directors of AIIMS New Delhi, and only few lead in the newer AIIMS institutions. There are also instances, as we all know, of violence at workplace. There are usually verbal abuses, and there is also the glass ceiling effect. The glass ceiling effect refers to there is a discrimination in the policy of promotion or a woman rising to a higher level of administrative position. Though she can, but there are various factors like the home responsibilities, like the male dominance at the workplace, which will not allow a woman to rise above a certain position. There are also instances of women workers or women healthcare professionals being dumped with extra work apart from what they have been assigned, though they are not later promoted to any higher positions. They usually remain the soft targets in such healthcare organizations. Now, coming to the social inequality in terms of accessibility to education for women. So, inaccessibility to education for women refers to their ability or inability to enter the education system, to continue and benefit from schooling without social, economic, or cultural barriers. Therefore, enrollment is the main focus here. In many parts of India and other developing regions, access for girls has improved, yet challenges still persist in the society. Firstly, we see that economic constraints often limit girls' schooling. In low-income households, families may prioritize the boys' education, while girls are expected to help with domestic work and care for siblings. Costs related to uniforms, transport, books, and digital access can further restrict their attendance and thereby prohibiting the girls for further accessibility to education. The second aspect is social and cultural norms influence educational access. Early marriage, gender stereotyping, concerns about safety during travel to school frequently reduces girls' participation in the education system, especially at the secondary level. In some communities, educating daughters is still viewed as less beneficial than educating the sons. The third aspect is infrastructure and institutional factors that affect the accessibility of education for girls. Lack of nearby schools, inadequate sanitation facilities for girls, of toilet and lavatory, and also whether they have access to proper water or not, determines their attendance. The sanitation facilities for girls, shortage of female teachers, and unsafe school environment can discourage regular attendance of girls, and it increases the dropout rate among girls in the schools as well as in the colleges. The gender gap in education in India, according to the World Economic Forum Global Gender Gap Report of 2025, states that India performs much better in educational attainment though than in terms of health. The country achieves a high parity score, about 97.1, indicating that the gender gap in education is almost closed. However, there are various critical aspects to be looked at. The improvement is driven by increased female literacy rates, higher female participation in tertiary education, continued near parity in school enrollment levels, and globally, the report notes that education gaps are already small in most countries, with many economies closing over 90% of the gender gap in education. Therefore, the overall interpretation of education sector in terms of India is that the gender gap with regard to education is largely being closed. Female literacy and higher education enrollment is yet to improve. Some disparities still remain in literacy and access levels. Now, what are these discrepancies or what are these barriers? So, therefore, despite these barriers, government schemes, scholarship programs, free textbooks, midday meals, and campaigns promoting girls' education have significantly increased female enrollment and literacy. The overall improving women's educational accessibility requires not only expanding schools but also addressing aspects like poverty, safety, cultural attitudes, and institutional support so that girls can complete education and pursue economic and equal opportunities. So gender inequality in education sector in India has narrowed in recent decades, yes. Yet it is important to understand that disparities remain in access, in retention, and in outcome. Government programs and social awareness have helped increase girls' school enrollment, and national data show near parity at the primary level. Reports from the World Economic Forum indicate that India has closed 96% of the gender gap in educational attainment, and it suggests substantial progress in basic access to schooling. However, equality in environment does not always translate into equality in opportunities. Girls, particularly in rural and low-income households, face barriers such as poverty, early marriage, domestic responsibility, and safety concerns that contribute to higher dropout rates in secondary and higher secondary levels. Social norms in some communities still prioritize boys' education over girls, and therefore the long-term academic and career prospects of women become restricted. Higher education participation among women have improved significantly, supported by scholarships, reservation policies, and initiatives promoted by bodies such as Government of India and the UNESCO. Yet, gender gaps persist in fields like engineering, technology, science, technical training, where female representation remains very low. Thus, while India has made strong advances in expanding girls' access to education, achieving true gender equality requires addressing social attitudes, safe learning environment, reducing economic barriers, and promoting equal opportunities across all levels and disciplines. Therefore, in this module, we have learned about the factors that affect the accessibility to healthcare and education among women, among girls, and we have learned about the social inequalities and the extent of gender parity for health and education through the Global Gender Gap Report of 2025 done by the World Economic Forum. We have also analyzed the social determinants of health and education leading to gender inequalities and some change that is required in perspectives that will help us to move towards a more just society. Thank you.